Hello everyone, Peter Frampton here, yet again, Peter Frampton, owner of Erin Optometrists. And this is a talk I've been asked to give somewhere else, and I thought I'll just record it for myself anyway. People, students and so on might be interested in it. It's called MECS, IP and Optometry and Doctor. And there's been a lot in the optometry press lately about perhaps us starting to call ourselves doctors. And it's an interesting debate topic. You know, in America, they're ODs, Doctors of Optometry, and there's a lot of people here. Now, I do think that the people who are throwing this out there are possibly not the best people to actually decide that we should be called doctors. They haven't seen the sharp end of a slit lamp for some years, I suspect. But it's all very good saying. So I thought to myself, are we all really ready? You know, we've got MECS now. MECS is being rolled out. For people who maybe don't know this, if there's patients watching this, that's minor eye condition service. So it's trying to get a service out there where you don't go to the doctors, you'll come to an optometrist as well instead, which is much better for doctors. I think it's a little bit easy. I'm not very fond of it, but you know, it's an easy entry thing. Then there's IP, that stands for Independent Prescribing Optometrists, of which I'm one, and my colleagues are also. So we're starting to call ourselves medical optometrists, and so we prescribe licensed drugs. And so I got mine in 2009, and it's the biggest game changer for me ever. I can't imagine working without this medical optometry stuff now. We use it all the time. And then there's Doctor. And I want to test it, right? I want to see if we're really ready. So let's look at our evolutionary pathways for a minute. So first of all, our traditional pathway we started off, I believe, you know, as lens grinders. That's what we did. And then we became refractionists, where we tested people's eyes for glasses, but we did nothing else. Then we became screeners, where we'd screen for certain diseases, and if an abnormality was detected, we'd refer it on, but we didn't have to do much thinking about it, we just referred it on. But now, what this is suggesting is, if we're going to call ourselves doctors, we have to take an alternative pathway now. We have to be up there, we have to become diagnosticians, we have to officially diagnose something. It's no point just screening it and saying to the doctor, I'm not sure what it is, but it's wrong. You know, we have to be able to tell the doctors what to do or do it ourselves. And that moves on to medical optometrists, of which I classify myself as one. And then there's calling ourselves doctor. And okay, I can call myself doctor because I've done a doctorate, but it's a slightly different thing. But the leap from that is a big one, right? Optometrists have to jump. And psychologically, it's a big barrier to sit there alone in your little room on your own, and you're actually saying, right, I think I know what this is, or I'm very sure I know what this is, but I'm not going to just send you off to the hospital. I'm actually going to sit here and do it myself. That takes a huge level of confidence and competence and experience. And an awful lot of people aren't really quite prepared to do it. So let's check. So this is a test for optometrists, right? Now, I'll give you my little mantras first. First of all, I ask myself, when I'm dealing with the patient in the community, I say to myself, what's in the patient's best interest? And does my clinical management plan, the plan I'm going to put together to help this patient, does it differ in any significant sense from a hospital one? Now, this is important, right? So, and the two things link. If I sit here in the community and I know that if I send the patient to the hospital, they're going to do exactly what I know I'm going to do, then I can't see any reason why I'd refer. And therefore, and in fact, it's not in the patient's best interest. Why would I drive them 30 miles to the nearest hospital, have them sit for 4 hours, have the GP get billed for that, incidentally, when I can actually do it there and then? Conversely, if I know that something needs, say, a culture done, which I'm incapable of doing in my practice at the moment, then it patently isn't in the patient's best interest for me to deal with it because they need to have a culture. So they're my simple rules. Now, there's a whole debate about how you get that knowledge, right? There's a whole talk there in itself. But that's my fundamental rule. And I will never refer a patient, unless they want to, I'll never refer a patient on if I can do it myself. But secondly, we have an extremely stringent audit cycle in our practice. You know, a diagnosis very rarely is a true, full-on, definitive diagnosis. It's actually a working hypothesis based on the best evidence. So we prepare a clinical management plan, and really it's important for all optometrists to do this. If you're going to take up this stuff, record your logic. And if you record all your logic, you can't really go wrong, right? But if you don't record it and things go pear-shaped, you haven't got a leg to stand on. I think students are always told you're either going to be wrong or you're going to get struck off. And it's strictly not true. If you've got a good logical plan and you've covered all your bases, you're actually fine. Then you start your treatment and then you do your meticulous follow-up. Meticulous follow-up is absolutely mandatory, especially if you're not sure of yourself. You don't wait a week. You see them a lot. That keeps you safe, it keeps the patient safe. And if the evidence is not shaping up the way you want, then you may adapt your clinical management plan. So we go through this all the time and outcome audit everything, even if you've referred them to the hospital. Bring them back in and review them, because that's the way you learn. The other really important thing is to include the patient in the plan, right? You know, if a patient sits down in front of you and says, "Oh, I'm really nervous about this. I don't," for heaven's sakes, don't treat them. Send them off. You know, they have a right to be part of the plan. It's ridiculous to do things to patients without their knowledge, and have the open conversation. I mean, I had a conversation with Sonia, my lens practitioner. She brought me in to look at something, and she says, "I think it's sterile, so I'm going to treat this way." I said, "That sounds perfect, makes perfect sense." The patient is there, she's involved with the conversation. I said, "Well, let's try it this way instead." And the patient lived quite locally. She was happy to come back in 3 or 4 hours and let us have another look. In 3 or 4 hours, we decided it wasn't quite what we thought. We changed it and we treated it differently. But the patient was involved in the process. It wasn't me and Sonia discussing something. It was the patient and us discussing it together and coming up with a plan that suited all three of us. If the patient said, "No, I can't come back in for it," then we may have treated it differently. And then it's logic. With a lot of this stuff, you know, it's as much about logic as knowledge. And you've got to sieve things. Andrew, who I work with, told me a story about Sunderland Eye Infirmary where he did pre-reg there, and this ophthalmologist said to him, "For heaven's sakes, if you ring us and ask our advice, don't ring us and tell us what you think it is. Don't ring up and say, I've got a corneal ulcer, what am I going to do?" Well, frankly, if you've got a corneal ulcer, you know what you're going to do. You're going to refer them to the hospital. This ophthalmologist said, "Please describe what you see." And this is how ophthalmologists learn. They don't learn from a Kansky, they don't learn from a book and say, "Oh, it's that." They describe everything that they're seeing, they look at everything, and they come up with a working hypothesis of what that might be. And sometimes you don't come up with the ultimate diagnosis, but you sieve it. Sieving's important, and I use this little mnemonic ditty. So if you can sieve it down to either a degenerative thing, infective, trauma, or inflammation, you're there. You know, if it's inflammation, you're going to treat it with an anti-inflammatory. If it's infective, you're going to treat it with some form of anti-infective. If it's trauma, you remove the trauma or treat the trauma. You know, it's works that way, right? And don't think, as young optoms, don't think you've got to make a definitive diagnosis every time. But so long as you're confident in the region, you know which way you're heading. Now, we all talk as well about red, vision, pain. Right, they're the three classics. If you get someone in with a red eye, vision poor, and it's painful, that rings every alarm bell. But there's another one, there's laterality. Is it both eyes or is it one eye? And I think that's really important. I want to give you an example of that now. This is an angular conjunctivitis on the one side, and on the other side is an episcleritis. Now, I've used this before. This is an important case for me, not because it's sight-threatening, it wasn't. It's because of what it taught me to think logically. When I first saw this patient in the room, I saw two eyes and I thought, "Oh dear, that's episcleritis." But as I walked towards the patient, I thought, that's not logical. The chance of you having episcleritis in both eyes at the same time is actually pretty minimal. And when I looked at everything properly and I observed everything and I noted down what I saw, I realized that this had every sign of a conjunctivitis. There was a mucoid discharge, there was blepharitis, there was a lot of weeping and so on, which with an episcleritis you wouldn't get. And also an episcleritis, logically, I mean, you could have it bilateral. If you've got bilateral episcleritis, I think you've got a fairly sick person. And so I took a close look at it. Now, I'd never heard of angular conjunctivitis at that stage. This is years ago. But logic told me this was infective. So I treated it at the time with a thing called Polyfax. I don't think you can get it now. and it went away. So I looked it up, and it's caused by something called Moraxella. But the point is, you won't know every condition unless you're a consultant ophthalmologist. You just won't know. All you got to do is know your logic, think logically, and you come up with something. Right? So this was a really enormous learning one for me. So in my optometry clinic, these are the drugs I tend to use. I have ciprofloxacin, I have ofloxacin. These are all licensed drugs, remember. You know, if you're not IP, you can't get these. I've got olopatadine for allergy. I've got ganciclovir for viral keratitis, and I've got 2 steroids. I've got a really strong one, Predforte, and I use FML a lot as a soft steroid. And then if I need systemic antibiotics, I tend to prescribe via my GP, and the GP usually gives it to them. So that's what we've got to play with, right? So that's your workbook now, right? So let's move on to some real cases and see what you're going to do. Now, if this is being done live, this is going to be out there, right? But so first patient is a male contact lens wearer. It's an emergency appointment. He pays me a professional fee for my services. So he reports a 24-hour history of sudden onset ocular swelling and irritation, left eye only. Vision's fine. He felt he rubbed his eyes, and he removed the lens immediately and came straight in. Now, looking at it, that's chemosis. Chemosis is a classic sign of inflammation, but usually acute inflammation. The fluid's just built up. You've suddenly had something traumatize your eye. I don't know what it was. He may have rubbed his eye. I don't know what it was. But suddenly had this acute chemotic inflammation of the bulbar conjunctiva. Now, it was so acute, I didn't make a specific diagnosis. We never got to the trigger. We sieved it. We got down to the category. I was quite happy to treat it. And in this case, I treated it with FML, fluorometholone. If I hadn't treated it at all, it would have gone away. Well, I'm sure it would have. Because the trigger had gone, whatever had done it had gone away, it would have gone. But, you know, they're paying me money. I like to treat it quickly. So that was that one. Easy one to start with. Right, 50-year-old female. General health is good. She's not on any medications. The left eye is achy and red for several days. Now, I hope you can see that slit lamp scheme. It's obvious she's got anterior chamber flare. Now, what are we going to do with this? And what sort of questions would you want to know before you treat it? First of all, it's unilateral. That's really important. The patient's health is good. That's important. There are no red flags. So if someone like this with an iritis like this had other things, you might treat differently. It's the first episode. She's never had it before. That's also really important. And really important is it's monocular, right? But coincidentally, when I asked her, she did say she had a bit of lower back pain, and that pricked a couple of things for me. And I thought, okay, it might just be that you've got lower back pain. But it was enough for me. I was going to treat this directly, but I thought to myself, actually, I will write a letter to the doctor anyway. I'll treat it, but I'll ask the doctor to do some blood screens. So I asked for HLA-B27 because people with ankylosing spondylitis, as you know, are also prone to iritis. And I thought, well, lower back pain, it could be. She was so fit, I didn't think it would be the case, but blood tests are pretty cheap. So I felt at the time I wanted to do that. They came back negative. She was absolutely fine, but at least I can tick that box. So I treated this directly with Predforte, and you really hit it hard. You know, you put it in every hour for a week, then every 2 hours for a second week, then 4 times a day for a third week, then twice a day, then once a day. So you really have to hit this hard. And obviously, the other thing is you obviously dilate the pupil and have a really good look that there's nothing at the back. It's truly iritis, not uveitis in any form. And so long as you're sure of all that stuff, treating it's fine. If I sent that woman to the hospital, that was what was going to happen. Now, but let's have a look at it. So in this case, I did not involve the hospital. It was a treatment regime between the optometrist, the patient, and the GP. But there's a really good resource out there called Medscape, and I think it's worthwhile logging onto this. You've got to register. It's not open to the general public. But if you say you're a healthcare professional, it's your business, right? It's so much better than looking up cancer or anything like that. And it tells you what to do. If it's first episode, and if there's no red flags, so there's no general health issues flagged up, then you just treat the acute episode. If on the third episode, if you've had 3 episodes in a row, then they're suggesting you call in further tests. But logically, if it's bilateral, don't touch it with a barred pole, right? What's the chance of someone having bilateral iritis if they haven't got an underlying problem of rheumatoid arthritis or ankylosing? They've got something. So as soon as it becomes bilateral, wham, they're off. And if it's granulomatous, anything like that, or if you see anything at the back of the eye, then that's a different thing. So unilaterality in this is really important. So in this case, patient's case, everything else was good. It all came back negative. I treated it, and she's never had another episode. And this was, gosh, easy 4 years ago now, this patient. Right? So logic, and unilaterality of the eyes, bilateral, monocular, that's really important stuff. So here's our next patient. This is an interesting one. I like this one. What's the clinical management plan? Have a look at that image. Now, this is classic. This is what would happen as an undergrad. They give you an image, you've got to diagnose it. Well, you know, that looks scary. That fluorescein is really penetrating the stroma. I think we can all decide that looks pretty dendritic. So you're going to refer. But let's think about it. Let's just keep calm, right? Let's keep calm and civet and see if we can't maybe deal with this, right? Now, initially, we all have our own red lines, incidentally. You know, when I first started prescribing, I always said, if it was stromal, I wouldn't want to deal with it. I want to refer. But gradually, my confidence level's just grown over the years. This does not come overnight. You've got to work at it. And then I thought to myself on this one, actually, I know what's happening here. I can deal with this. So let's have a look. So first of all, that fluorescein was not instilled by me. It was instilled by the accident emergency at a local hospital, not an ophthalmology department. The case history, she had a mildly painful right eye for about 2 weeks. So what does that tell us? This has lingered on for some time, you know, and it's only mildly painful. An MK or an acanthamoeba is not going to be mildly painful. You don't put up with it for 2 weeks. It's been untreated for 2 weeks. Right? And it was the A&E that instilled the fluorescein, and they said it could be a foreign body, you better go to the hospital. So that tells us straight away that we're much, much better than we give ourselves credit. You know, this is a hospital, this is doctors. Now, okay, they're not ophthalmologists, and I don't blame them for what they've done. They said, you should go to the hospital eye service. But she came to an optometrist instead, which is how it should be, right? It's grand when people say, well, actually, I'm not going to do that. I'm not going to drive 40 miles. I'm going to go to my local optometrist and see what they say. And that gives you great confidence, and that's great. So you've got time on your side because this has already gone on 2 weeks. Now, the other thing is, before I started treating this sort of stuff, you need to be aware of their medications. You must learn to do this. This is really important. And I'm slightly embarrassed to say to you that this is the list I had on my clinical case records, right? They'd written all this, someone in the past had written all this down, and they'd listed a whole lot of drugs there. Now, if this was going live, what I would like you to do, if you wanted to, have a look at that, try to put it together into some semblance of order. Take what we know she's got emphysema. What drugs at the bottom would link to emphysema? She's got blood pressure. What drugs? Can you do that? Right? Now, I don't think a lot of optometrists we still take these drug litanies, but I'm not sure we actually always really know what to do with them anyway. So I pulled it all together because she's on prednisolone. Now, prednisolone is going to reduce your immune system. So therefore, does that make you want to treat, or do you think, is the treatment going to be a bit dodgy because your immune system's shutting down a little bit, or is slightly reduced? So this is what I got. This is when I put it together. Yes, she's got emphysema, COPD. That's why she's on those inhalers, salbutamol, fluticasone, and so on. Tiotropium, classic drug, only used for COPD, not used for asthma. And she's actually on the prednisolone, not for an inflammatory disease. right? She's not got rheumatoid arthritis or anything like that would really suggest, okay, that really would be a red flag. If she had serious arthritis, you'd be thinking, I'm not sure I really want to treat this, right? And she's also on carbocysteine, which is a mucolytic. She's got the osteoporosis, that's what the alendronic acid's about. She's got the back pain, and she's got enalapril for blood pressure and so on. So suddenly that makes a lot more sense, I'm wanting you to agree with me, than the gobbledygook on the other side. And once you've got that down, you can suddenly think to yourself, right, I've now made my diagnosis, I figure I know what it is, but I also feel that she's robust enough for us to treat it. She's not going to need further stuff. So what do we do? So are you going to treat it? And what would be first, your best hypothesis, A, and best hypothesis B, because I'm suggesting to you there's two things going on here. And then what is your clinical management plan for both those hypotheses, right? And then what you need to do as well is try to incorporate a review schedule. If you were dealing with this, think about, even if you're going to refer, think about it. When would you bring them back in personally? This is how you learn. Pretend, even if you're not going to do it yourself, pretend you're going to do it yourself and do it. And come up with a theoretical plan. So what I did, we've decided this is, in my opinion, this is active viral epithelial infection, hence the dendrites. But because of the dramatic stromal infusion, I've decided that's become interstitial keratitis as well. So there's an inflammatory process going on there as well. Now, of course, we're all told, so how are you going to treat them both? So what I did first of all, because it's been going on for 10 days now, I treated it hard. I gave them systemic antiviral, acyclovir 400 milligrams, and I also gave them ganciclovir ointment to put in 5 times a day. And I set the review date for 3 days. Now, if I'd done this 3 years ago, I would have set the review date for the next day. But I was confident enough with what I'm doing now to actually allow this to go for 3 days, which is what I did. And when she came back, the active and viral infection was really getting under control now, but there was still a lot of stromal stuff going on, this interstitial stuff. Which interstitial stuff is basically an inflammatory response. So we're dealing with an inflammation and an infection in this case. So we need to get rid of the infection first, then we start dealing with the inflammation. So that's when I started giving them Pred Forte, twice every 2 hours for the interstitial. But patently, I only did that when I'd really nailed or controlled to a large extent the active viral infection. And I kept them on all the antiviral stuff while we did this as well. You're not going to take them off that and then give them the steroid. That's going to allow a virus to just bounce back and come back big time. So I reviewed in 10 days. It was completely resolved at that stage, but I tapered off the steroid, kept her on the antivirals throughout. And I've also talked about the possibility of doing prophylactic stuff via a GP if she has any recurrences, because sometimes these people need to stay on an antiviral for a long, long time just to keep it under control. Now, that's way out of the comfort zone for most people, and it was way out of my comfort zone even 3 years ago. But that's how you learn. You develop things and you do things as you go. So here's an interesting one. Now, this is an easy one. We could all be faced with this. This guy's a patient of ours, but he's also a patient of the hospital system. He's got scleritis, full-on scleritis. He's had it for 20 odd years now. And he's under corneal specialists at 2 hospitals, actually. But he pays me privately as well. He's on my professional fee service. And he likes to ask me questions because hospitals are a bit overworked and they don't always tell you things. And he came in with his prescription. Now, he's been on this stuff called mycophenolate for ages, and he told me that he's been taken off that now. He did say that it worked very, very well. It kept the scleritis really in control, but he seemed to get a lot of colds and things. So he wondered why that was, and he wanted me to answer it. And then he also brought in his prescription. So at the moment he's on Lotamax, he's on something called Optimune, he's on Viscotears, Vitapos and Clinitas. And he wants to know what these things are for. Because he thought he might put some in the other eye as well, and he wanted to know which ones he could put in just for general eye comfort. So how are we going to find this stuff out? So first of all, mycophenolate, and why on earth was he taken off it? I'd never heard of it before. So how do you find these things out? And you do it in front of the patient. There's no harm in that. You bring up your electronic resources on the internet while the patient's sitting in your chair. So Electronic Medicines Compendium, it's my go-to. It's open to the general public, it's open to everyone. And you type it in and you come up with a drug, and there it is. It's indicated in combination with cyclosporin for the prophylaxis of acute transplant rejection, right? So this is a pretty serious drug, and this is way off license, right? And obviously we're never prescribing this. This is from the consultant. But it shows you the sort of drugs these people use, and I learned something from this. And I was able to explain to the patient. Of course, these sort of things are so reducing his immune system. This is why he was constantly and always getting colds and so on. So it's understandable why the consultant ophthalmologist thought, yeah, I think we'll take you off this. So I learned something, he learned something, it was great. And then the other things, let's have a look. One of the drugs I'd never heard of before. So when you go into Electronic Medicines Compendium, just start typing it in. Now it's spell specific. So if you start typing it in, right, we're going to type O, PT, there we are. And suddenly you can tell it's not there. Optimune isn't on an SPC. So you think, well, whatever drug this is, they ain't using it licensed. This is an off-licensed drug. So I had to go straight onto Google, and there we are, Optimune. It's actually licensed for dogs, right? And when you look it up, it's actually cyclosporin. So it's an immunomodulator, and I was able to explain this. But this is classic. This cyclosporin is a great drug. In America, it's licensed for general use, but in this country, it's really only for vets. Vets can use it, humans can't. So there I was able to explain to him. I already know what Lotomax is. I was able to explain that's a soft steroid. Optimune is cyclosporin. And then we've got the Viscotears, the Vitapos and the Clinitas, which are all for eye comfort, which they're the ones he could swap to the other eye if he wanted to, and it wouldn't hurt him at all. But you have to know where to find this information. If a patient's asking you, even whether you're not an IP optom, a patient might ask you this information, and I think it only looks good for you if you're able to tell them. So this is another one though. This is a revisit. This again is one of those seminal patients for me where I learned so much. This is a 24-year-old contact lens wearer, daily wear silicone hydrogel. She's stringent, she's good, she's a really bright woman. She's back from Oxford University for the summer break, and she turns up with this little lesion here. So what are you going to do with it? What's your diagnosis, or what's your working hypothesis? What's your clinical management plan? And what's your review schedule going to be? Now, if we look at the clinical management guidelines from the college, this is for a sterile contact lens associated infiltrative event. It's peripheral, it's usually small. The overlaying epithelium might stain with fluorescein. Anterior chamber is quiet. There's no lid edema. Its pain level's very low. So, it would suggest maybe this is a sterile marginal corneal ulcer. And most signs go away. If you remove the contact lens, most signs go very promptly. But, and here's the but, the differential diagnosis is microbial bacterial keratitis. And I think that's the point. Your review schedule has to reflect the worst case scenario, not what you think it is, but the worst case scenario. So if you think there's even an outside possibility that this could be an MK, you need to be managing this quite rigidly, right? And also you need to have very meticulous follow-up. And if outside your comfort zone, you must refer on, so if you're not sure. So basically, this was treated by a non-IP optometrist, very experienced non-IP optometrist though. He did decide that it was a marginal keratitis, and he treated with chlorphenicol, and asked to come back in 2 days. Now in 2 days, or he said return if SOS, so if it got worse, return. She did return in 2 days, I was in, that's what I saw. Right? This woman was hospitalised for 5 days. She lost her entire summer break to this, and her vision still 6/6, they controlled it, but she was in hospital for 5 days. Round-the-clock antibiotic cover, really tough stuff, right? And this is the thing. IP is so important. If in doubt, assume that it's infective. Because there's got to be a stage when an infection gets in, and it's so early days, it hasn't shown any great pain. It's got to be small. MKs are not always central. They're not always really painful. They're not always huge. They are ultimately, but if you see them in very early days, they're not gonna. So this is why IP, independent prescribing optometry, is so important. MECS, I can take or leave. So back to this thing, this is the whole thing. I'm going to put this in. This is because of medical optometry. Remember, IP has changed my life, right? And contact lenses are the classic. They are the cause of so many things. And as a medical device, I really say to you all optoms, we should have a medical-based level of skill. Being screeners, sending off to the hospital is not good enough. It actually puts patients at risk, like that patient there. It's MKs, it's inflammation. And what do? When we have all these problems, we either risk by taking time out to see if it gets better, which is putting the patient at risk, or refer them. And if it is sterile, it's more likely to be sterile. So if you refer every sterile looking ulcer, you're going to over-refer. But that's our normal. And it's just counterintuitive. It's absolutely counterintuitive. So I would urge people, think about this. This is really important. And it's one of my big selling points for contact lenses. When I sell my contact lens service, I'm not saying to them, here, buy my lenses because I think they're great. I'm saying, buy my service because I think it's great. Right? That's what I'm selling. And that's really important. So MECS, IP, doctor, that's our evolutionary pathway again. Where do you think you stand on it? There's some of the things I deal with. You've got to be thinking about this. I think that mooting around this idea of doctor, I think we really have to have some. I think we can all do it. I think it's great for our profession. But I don't think it's something you just label on. I think we have to earn the right to call ourselves doctor. Thanks very much.